Good morning, ladies and gentlemen. Welcome to this sponsored session. This session is sponsored by Microport. And the idea of this session is that we introduce you to the Microport VitaFlow system. My name is Darren Mylert. I'm an interventional cardiologist from Galway, and I'm joined by my good colleague and friend Elizabeth Rosseel. We have a great panel today. We have Thomas Modine, Lars Sondergaard, Matthias Steffman, and Angela McInerney. And joining us online, we have three of our Chinese colleagues who have the most experience with this system globally. We have Professor Jumbo Ge, who did the first implant in China many years ago from Zhongshan Hospital. We have Professor Wu joining us as a discussant from Fuwai, and Professor Song, who's joining us from Anjin Hospital in Beijing. As we go through the presentations, our objectives are to introduce you to the VitaFlow system, first of all, to tell you how this system may be a good option for your patients with complex anatomies. And then we're also going to hear how this device is being adapted and used in anatomies that are somewhat unusual for us, patients with severe aortic incompetence. So we look forward to your participation over the next 60 minutes. Elizabeth.
Okay, and let us remind you once more that we kindly invite you to participate in this meeting, to pose your questions either online through the chat or here on site through the mics or via the app. Thank you. Our chat master is Angela McInerney.
So with that, it's a pleasure to ask Professor Jumbo Ge, who we see on our screen in front of us, if we could have Professor Ge on the main screen. And he's going to tell us about the VitaFlow system and about the 5-year results of their study. Professor Ge.
Okay, thank you very much, dear Thomas and dear Lars. Good morning, and Professor Wu and Professor Song. Good evening. It's my pleasure to join you during this PCR 2022 Learning Well. I would like to present to you the 5-year clinical outcomes of this Microport VitaFlow transcatheter aortic valve system. I do not have any potential conflict of interest to this presentation to declare. Yeah, first of all, I would like to briefly introduce this device. This device, as you may see, that is composed of 3 full components. One is with the upper part with the larger cells to preserve the coronary access in the future, and also it's the lower part composed of the high-density cells to provide a strong radial force, which is more suitable for very calcified and bicuspid valves. And it is also composed of this double-layer PET skirt, which is better sealing to reduce this perivalvular leakage, and also this supravalvular annular design to preserve the annular circularity to provide a bigger or larger orifice. And this delivery system is also rather special. It is composed of this electric handle, which is very operator friendly, because it's not necessarily just to release this frame by rotating. And thus you have a button just to push, it will pull this sheath automatically back. And this is easily to control, especially during the implant. The study design was easy. This is underwent 6 years ago to evaluate the safety and effectiveness of this VitaFlow valve and delivery system in patients with severe calcific aortic stenosis who were considered suitable for surgical valve replacement 6 years ago, as I mentioned. And this was designed as prospective multi-center single-arm trial, and it was supposed to enroll 110 patients. The all patients will be followed up 30 days, 6 months, 12 months, and 2 to 5 years. This is the final follow-up according to the protocol, 5-year results. The primary endpoint of this trial was to evaluate the all-cause mortality at 12 months And the secondary endpoint was the device success, procedure success, major stroke, and valve performance, improvement of heart function, and the major adverse cardiovascular and cerebrovascular event, and the improvement of the life, of the quality of life, etc. As a PI of the study, we have colleagues from Hubei Hospital, from West China Hospital, and also the second field hospital of Zhejiang University School of Medicine as co-PI center. And we have all together enrolled, as I mentioned, 110 patients. And Dr. Nicolo Piazza was the CT to play the core laboratory to analyze all the data. And the patient baseline is actually not different from the other trials. The mean age was 77 years old, and 2/3 was a male patient with the mean SES score was 8.84. And what I want to point out is we have 38% of all the cases with bicuspid aortic valve, and the other 62% was non-bicuspid valve. And the others are roughly the same as compared to the previous studies. Yeah, you will see that because these are all Chinese patients, we have a 94 patients through transfemoral approach, and the 24 and 27 millimeter valve took the majority. We have only very minor patients with tiny, smaller and bigger valve. And this is actually the most important slide of the study. You will find this the red dot illustrates the effective orifice areas. And after implantation, it is stable by 1 year follow-up. And this is the blue dot illustrates the gradient change after implantation. You will find a dramatic decrease of the aortic pressure gradient, and it is also stable by follow-up. And by the 1 year follow-up, you will find that actually only 1/4 of the patients with a mild, we call maybe perivalvular leakage by the 1 year follow-up. Most patients, more than 70%, with a non or retrievable perivalvular leakage. And this slide illustrates the heart function change. You will find that by 1 year follow-up, and also more than 70% with improved cardiac function, on only with 30% with the New York Heart Association function of 2 to 4. Only one patient with a class 4 the classification. And the result, actually, I showed you last year by the 4-year result. This is a 5-year result. You will find that the total all-cause mortality by 5-year follow-up is 20 patients died, which was 18.2%. And the cardiovascular mortality is 9 patients of the all 110 patients. It was 8.2%. And the pacemaker of no exchange, vascular complication was stable, just compared with the 1 month. That means 30 days, no further vascular complication, and the stroke all stable. And the other 10% actually died not of the cardiovascular cause. And we also analyzed the subgroups regarding the bicuspid versus tricuspid. You will find in the bicuspid group, it seems to be the age was younger, and the STS score is less than that of the tricuspid. And because we know that the bicuspid valve will occur the valve stenosis earlier, this is also understandable. All the other parameters are similar in both groups. We compared also this hemodynamic change and also the mortality. The all-cause mortality was comparable in both groups, and even by the 5 years. And also the cardiovascular mortality, even though there's no difference, but it seems to be this bicuspid even lower because the volume of the patient is too less, and we cannot reach the difference. But in this group of patients, is comparable. And also all major strokes in those groups are similar. And we also compared regarding the hemodynamics. You will find that the mean aortic gradient by 12 months was similar. And also the aortic valve area by the 1 year follow-up also similar. There's no difference in both groups. Therefore, based on our result and also the long-term follow-up, clinical follow-up, we can conclude that the low all-cause mortality and the cardiovascular mortality rate at a 5-year follow-up of this platform. The all-cause mortality rate at 5 years was 18.2%. The cardiovascular mortality at 5 years was 8.2%. No significant difference between clinical outcomes of the bicuspid versus tricuspid group. And also the 5-year clinical outcomes support the safety and efficacy of MicroPort VitaFlow in the treatment of patients with severe aortic stenosis. Thank you very much.
Thank you, Professor Ge, for that important presentation and for setting the ground for our discussion. Can I ask you one further question? Is there a plan to follow up these patients to 8 and 10 years so we can get some durability, some further durability data?
Thank you very much for the question. Actually, according to the protocol of this study, is for the 2 to 5 years follow-up. But according to our, we build the 12 center China, and according to the data bank, we try or we advise to follow all the patients up, and they upload all the follow-up data and as long as possible in the 12 center.
Excellent, thank you. Lars, you're a trialist. You have lots of, I suppose, involvement in these types of trials and studies. Do these 5-year data impress you? What are the salient points?
Yeah, I would say if you want to look at the effectivity or safety of the procedure, you should probably not look at 5 years. I would look at the 30 days. The 30 days is going to tell us how safe is the procedure. And you saw here all-cause mortality in this quite old, high-risk cases was less than 1%. There was none of the patient had a stroke. So it looks like it's a very safe procedure, as I see it. Looking at the 5 years data, it seems a little the data we have seen here that durability of this valve is sustained. It's the same opening area, same low gradient. So I think it's encouraging from what we have seen here in a patient cohort at elderly age, 77 years of age, and STS score of 8%, which is pretty high. So quite encouraging data.
Thomas, you were involved with this study when it kicked off. What are the features of this device that impressed you, or that mark it out as different from other devices on the market?
So the different features in this device were very surprising when we tried it first back 5 years now, Darren. This hybrid construction of the stent itself, which make really a difference. High radial force at the level of the annulus, which explain also the good results with bicuspid, without taking a risk of using a balloon to open the valve. The large cells to guarantee a coronary access, and the soft cells at the level of the aorta, which minimize also the risk of the aortic dissection, which can happen also. The other thing really which I really liked and it showed to be very different and reliable in terms of accelerating the teaching and the adoption is the motorized system. The deployment appeared to be much more progressive, much more controlled, and the distal nose cone have been able to centralize a bit, and it gives you a centralized opening, which I think helped us achieving a very low rate of probable leak. And again, remember, this was 5 years ago.
Yeah.
Without commercial alignment, we didn't really used to implant high as we do it today. So, I mean, a valve that we used 5 years ago, it had already features of all what we want today.
Yeah, Matthias, when I first saw the motorized I suppose, unsheathing of the valve. I felt that this was a little bit of a gimmick. I think we've learned since then that it actually provides a very stable deployment. What are your impressions of it, and why aren't more companies using this method?
Yes, as you say, the motorized system give us some stability that we don't have with other devices. And the most important feature of the motorized device is that the second operator that is using the button to release the valve do not transfer any movement to the first operator. So that is important in the final part of the release, because the valve at the end, at the final part of the release, will not move, nothing. Will be on place, and this is difficult to have with other devices. Yeah. Sometimes with other devices, in the final part of the release, there are moved upwards or forwards, so that is a good feature.
I see we have Professor Wu online from Fuwai Hospital. Professor Wu, if I can ask you, in terms of your day-to-day clinical practice, are there particular patients that you choose for this VitaFlow system? Do you choose this for simpler patients, more complex patients, or where does it fit into your clinical practice?
Okay, thank you very much for the question. So, and we start the TAVI program the 10 years ago. So the first device is the VitaFlow. I think is the all friends that know the VitaFlow. So this the VitaFlow is the second device in China, and we started to use it at the beginning in the relatively the simple the patients. But at that time, so this the VitaFlow is the first generation of it's the first generation, so it's not retrievable. And that time, so we are very carefully to select the patient. So this is the reason why in this trial, the bicuspid account the 1/3, but in the VitaFlow, in VitaFlow trial, the bicuspid account nearly the 50%. So I think it's the earlier stage of this trial. So the patients are very carefully selected. But at the end of that trial, so because that time we had some experience about the implantation. So and at the end of this the trial, we can use the VitaFlow for the relatively complex, and now we use in the nearly the 19% of the patient in the daily practice.
Thank you. Yeah, I think we need to remember that this data is generated from a first-generation device that was not retrievable, and as you said, Tom, no commissural alignment, no rapid pacing during deployment. Matthias, one of the things that we've learned in Europe over the last number of years is to maybe get the device a little bit higher to end up with less pacemakers. With the enhanced radial force compared to other devices on the market in Europe, are you seeing in Latin America, are you seeing more pacemakers than you would with other devices, or something similar?
No. That's a good point, because in my opinion, and I will show you with the results in our registry, it's not the valve itself, the pacemaker rate. It's the way you implant the valve. We start using VitaFlow using cast overlap. I don't know if 5 years ago the experience was using cast overlap. We start our experience in Latin America using cast overlap, and you are going to see the rate of pacemaker, the pacemaker rate is totally different of this information. Okay. So it's not the valve, it's the way that we implant.
Perfect. Lars, you're going to share with us a case.
Yeah.
So Lars and I were involved in the European CE mark study, which unfortunately got paused due to COVID, but is about to recommence. So we were lucky enough to treat some patients, but it's been a few years, Lars, so... Yeah,
that's correct. In Copenhagen, we got experience with 12 cases with the VitaFlow as part of the CE mark trial, which was stopped, at least paused during the COVID situation. So we haven't done anything since the last 3 years. But we did 12 cases. Of course, it's cases which has been well picked, study, good cases for study, so we haven't pushed the envelope yet to see how challenging anatomy we can actually treat with this. But we had excellent outcome in all 12 cases. So the case here, this was one of the cases enrolled in the study. Typical patient for TAVI, 74-year-old female, normal body size. She got a history of pulmonary embolism a couple of years before and was on a DOAC. Also have granulomatosis disease. And she was referred due to increasing symptoms. She was now in function class 2, also complained of dizziness during exercise. And the diagnosis during the referral was aortic stenosis. We did an echocardiography confirming this. She had a small opening area of the aortic valve. Annulus is 0.04 square centimeter, high gradient, peak 65 and mean 39 millimeter mercury. Normal LV function, mild left ventricular hypertrophy. There was nothing in her coronary artery disease. She was in sinus rhythm without any conductance abnormality, and her lab findings was unremarkable apart from a moderate impaired renal function. So this was a CT scan done here. You can see it's a medium-sized aortic annulus. Perimeter-derived diameter is 24.7 millimeter, matching what you actually found in the LVOT. No calcium in the LVOT, quite circular aortic annulus. And you can see it's a tricuspid aortic valve. Certainly some calcification, the wide sinus of valsalva, so doesn't indicate any risk for coronary occlusion here. ST junction also of a good size. And here you can see another view, severely calcified tricuspid aortic valve. You can see this CT scan where you're going up and down through the aortic annulus is also giving you some information about the calcium distribution. So I think this is certainly a challenging anatomy for a TAVI procedure, at least with the risk of PVL. So one thing I didn't show you here is an access vessel. Access vessels was suitable for a transfemoral approach, so that was what was done. So what is recommended here with this valve platform is that you do fluoroscopy to make sure that the valve is loaded correctly, as you've seen from our platform, TAVI platform, and here, in this case, it's not an issue with malfunction. So we did a pre-dilatation here due to the severe calcification. I'm not sure it's needed in all patients with this platform because of the higher opening or expansion force. We choose a balloon which was not too aggressive, 22 millimeter, so a little bit less than the minor axis of the aortic annulus, which was 23 millimeter. And you see it's good expansion here. You can still see here that there's a lot of calcium, big chunk of calcium here, but opening nicely up during the pre-dilatation. And then for the implantation here, again, as we already discussed, this valve have a motorized handle, which means that you don't need to turn a knob to open it up. You just push a small bottom and it will start to deploy. So you can do it very slowly, very controlled in this way. And you can even do it as one operator if you want, even though I think most of us will do it as a two operator. So starting here in the position where we approximately want to end, we are in a high position here, confirming that by angiography. And then next you can see that the valve is now expanding up. It's lifting nicely up here on the left coronary side. As we discussed before, you can see also, if you look at the fluoroscopy, this is done in an LAO projection. It's before we actually introduced the cusp overlap view, and I think also that explained the little bit high rate of pacemaker we saw from China here. And then again, confirming that the position is fine before we do the final release with the delivery system. Again, just push this bottom on the delivery system, and the motorized system will just slowly release the last part of the stent frame, pulling back the pigtail here. And then the valve is fully deployed. So this is the final angiography, angiogram here. There was done no post-dilatation. As I see, there was here on the immediately angiography only a trace PVL. It's a nice height position here. I would guess it's about 2 millimeters below the aortic annulus, again assessed in an LAO projection, not in a cusp overlap projection. So these are what we measured afterwards. Immediately in the cath lab, we did ECG showing that the patient had QS duration of 140, so a little bit broadened with a new left bundle band box, but it actually disappeared 2 hours after the procedure. ECG was normal, back to normal, no conductance abnormality. And the echocardiography before patient was discharged showed a large opening area, 1.9 square centimeter, low gradient. Here you can see a mean gradient, which is 1 digit, 6 millimeter mercury, with only a trace paravalvular leak. LV function is still normal, and with left ventricular hypertrophy. So that was one of the cases we did in Copenhagen. As I said before, we have done 12 cases so far with the system, all similar, very nice immediate results.
That's great. Thanks, Lars.
So maybe one question, or two questions actually. How about the hemodynamics during the deployment? Is it similar as a self-expanding supraannular valve?
I mean, as all supraannular valves, you will see a drop in blood pressure as the valves start to expanding up. You will have a partial occlusion. And what we do routinely is we pace during this phase. We don't do, in our institution, very rapid pacing. We pace 120, 130 just to bring the stroke volume a little bit down, to have the valve in a more stable position as we pass this middle third of the deployment, and then the valve is working perfectly normal, and then you can stop pacing and do your assessment before you do your final release.
Yeah. And then the other question here from the audience, what happens if the motor fails or the battery fails? Is there a bailout?
Yeah. There is actually a bailout, and it was shown here on the picture we saw before from China. You saw there was this white box with a motorized handle. Here you have this bottom for release. At the end of the box, there's actually a knob. So let's say it's going to fail, you can still manually release it as in the old-fashioned way, just turning the knob to release it.
Yeah, so I don't know, Matthias, about your experience, but in my experience with this system, it's only the battery has failed once, and of course it happened during a live case, so we had to turn it, use the wheel at the end. But again, they definitely have a fail-safe mechanism. Lars, come and join us. Let's be clear about a couple of the features of this device. So it comes in 4 sizes, right? It's bovine pericardium. The skirt is a PET skirt, which is very similar to the Edwards skirt. The other thing that was noticeable, Lars, was that because the top of the frame is so soft, it seems that final release, when you let the valve go, that there's no shifting or movement on the valve. Is that your experience?
That's correct. Some of the valves you see that as you do the final release, that it will make a tilt, quite a significant tilt, often go a little bit deeper on the left coronary side than when it's still in the capsule. It seems to be less with this system here. Again, it's difficult to quantify how much it is, but just my impression is it's a little bit less than you see with some of the other systems.
Okay. Thomas, maybe important to delve into the bicuspid, tricuspid thing a little bit, because of course we're used to seeing data only in tricuspid patients, but 42% with bicuspid is an impressive amount of information on bicuspids. Would you have expected maybe the short-term safety outcomes to be different in bicuspids compared to tricuspids, because it seems that they're pretty similar here?
Yeah, I mean, it's important to recall that this study has been designed to include all comers. So we didn't want to distinguish or eliminate these bicuspid patients. And, like me in China, bicuspid is not the same bicuspid that we see in Europe here. I mean, they are heavily calcified. And when I call heavily calcified, it's really big bunch of calcium, extensive, with spikes sometimes, that are really very, very challenging. I was not expecting this to work as well as it worked, but it definitely shows that a design with a higher radial force, like here, this hybrid approach of the engineering has made the difference. And again, the soft and progressive deployment has made this possible.
We have Professor Wu still on the line with us, I see. Professor Wu, can you tell us about what is your strategy in treating these heavily calcified bicuspids? First of all, what do you do in terms of sizing for bicuspids? And when using this platform, how aggressive do you predilate? And can you tell us some of the tips and tricks that you use to get these good results in bicuspid?
Okay, thank you. So actually, the VitaFlow and is really different from the other kind of the valves, because it's the different design of the frame. So as you said just now, so when during the releasing, so at the beginning, so the position is stable, but after release totally. So in some cases, the valve automatically dive into the left ventricular. Because only the very short part of the valve in the low part is the higher radial force, but in the upper part, the radial force is not very strong. So, and if I implant in the bicuspid, sometimes in the tricuspid, it's very calcified. So normally I prodilate, the Foley prodilate. Otherwise, it's the calcified leaflets can crush the valve, the VitaFlow, down to the left ventricular. So this is my first step. And the second step maybe is very important. So, and normally sometimes we depends on the performance of the balloon for prodilation. If the balloon, predilation balloon is the waist sign. So sometimes with the downsize selection and a little bit the high position. But now we realize that maybe this is not very correct true, because we also should the consider the height of the coronary osteo. And now so we little bit change our the idea. So we try to dilate fully and then to select correct the size of the VitaFlow.
Thank you. Matthias, of course, the data that we have on this system is from 5 years ago. The CE Mark study has been paused because of COVID, but you and your team have accumulated some data from your Latin American experience. Can you maybe share that with us? Yep. Would you mind? And I think that generating more data is extremely important with this system. Of course, we have good data from a small proportion of patients, 110 patients, but clearly we need more information before we would apply this liberally to other populations. So, Matthias.
Okay, thank you. I will show this early Latin American experience of VitaFlow. These are my disclosures. We start with VitaFlow in August 2021 with the classic one, and then we switch with VitaFlow Liberty in March 2022. This is what we saw in the first case: no conduction abnormalities, no PVL, no coronary obstruction, and extremely stable device. So far we have done 61 cases. And so we conduct a registry where we include 28 consecutive aortic stenosis patients treated between August 2021 and July 2022. And one important thing, that all cases were performed by the same proctoring team. The inclusion criteria was symptomatic aortic stenosis with indication for TAVI. All patients were treated with VitaFlow Classic or the VitaFlow Liberty. And the important thing is that all cases were done under CAS overlap technique. So this is the characteristic of the patients. The mean age was 79. The STS, mean STS score was 5.5. Just to figure it out, the CT Agatston score was more than 1,000. And we did only 2 bicuspid. This is because in Argentina or Latin America, there are not too much bicuspid cases. So the procedural characteristics, we did all cases by transfemoral approach. We use VitaFlow Classic in 46%. This is the non-retrievable one. And we use VitaFlow Liberty in 53% of the patients. The mean valve size that we use was 27. This is compatible with the 29 Evolute. And look the rate of predilatation. We predilate in 93% of the patients, but we post-dilate only 17%. Only in 5 patients we need to post-dilate. And the need of reposition of the valve was 28%. We did only 1 case of valve-in-valve, and we achieved procedural success in 100% of patients. All patients done by CAS overlap technique. These are the short-term outcomes. 30 days. We do not have valve embolization. We do not use more than 1 THV. We have not acute MA, stroke. We have only one major vascular complication with major bleeding that was solved with surgery. And in terms of conduction abnormalities, the rate of new LVB blocks was 60%, and the need of pacemaker implantation was only one patient, 3.5% in these 28 patients. In terms of hemodynamics, the mean gradient was 6.8, and the effective orifice area was more than 2. When we see what happened with the leak, you have a graphic with a lot of randomized trial, and the last one is what happened in our registry. We have only 24% of mild leak and no moderate to severe paravalvular leak. We also did a comparison between in our center, the last 25 cases that we did with Evolut and the first case that we did with VitaFlow. And as you can see, the need of pacemaker using cath overlap is exactly the same. One patient in the VitaFlow cohort and 2 patients in the Evolut. So it's exactly the same. So I would like to conclude showing how we use the valve in Argentina with a case. This is a 17-year-old female with some risk factor. Lifestyle is active. She has this dyspnea, New Heart Class Association 2 and 3, no angina. And as you can see here, the AKG shows incomplete RBB, no coronary artery disease. It is low flow, low gradient aortic stenosis with 30% of ventricular ejection fraction. The aortic area was 0.8 and the peak gradient 42. But in exercise, as you can see, the gradient increased to 52. So it's a low flow, low gradient with indication of treatment. This is the CT analysis, as you can see, very similar to the last case, 77 of perimeter, so it's an intermediate annulus with good sinus of Valsalva. But look, the aortic angulation is big, 62 degrees of angulation and very good coronary heights. So what do we do usually in Argentina with this device? We use cath overlap. We choose the implanting cath overlap view, then we predilate, as you can see. In this case, we did balloon sizing, but it's not necessary. And as you can see here, the implanting TriCath view, you can see the big angulation that has these patients. So in terms of the delivery of the valve, if you are happy with the position, it's very easy. You have to push this green button. And in this case, and always in all cases, we do pacing of 120, 130. And look, it's very easy to deploy and very, very stable. There are no movement of the second operator to the first operator. This is an important feature. Just to show the result, this is a LAO projection to show if there are contact in the left coronary sinus. As you can see here, there are. So if we are happy, we release the valve. Take out the nose cone of the left ventricle is very easy. And as you can see here, the result was perfect without leak. The valve was relatively high using cath overlap. In this case, the outcome, the patient was discharged 24-hour post-procedure without conduction abnormalities. And at 60 days, the patient recovered the ventricular function. So in conclusion, VitaFlow is safe and effective for treatment of severe aortic stenosis, even in angulated cases. Motorized delivery system helps to be more accurate during the deployment, do not transfer any movements. The hemodynamics are similar with other supraannular and self-expandable devices. And in our experience, using cath overlap, we achieve single-digit ppm in all cases. Thank you.
Matthias, come over and join us again. There's a question from the audience, but maybe before the audience question, we didn't see the access in that patient, and one of the differences between this system and, for example, Evolut or Portico is the size of the femoral arteries that are required. Tell us about the delivery system, what size it is and what size femorals you require.
Yeah, I don't show the axis because the time.
I didn't give you enough slides.
Yeah, you cut me the slides, but in terms of measurements of the axis, you need 1 millimeter more than other devices, because if you use the 21 or 24 valve, this is 16 French, but if you use the 27 or the 30 valve that are the biggest, you need 70 French to pass. So I think that if you have a calcification, you need more than 6.5 millimeters to pass through the artery.
Okay, so good femorals are a prerequisite.
Yeah.
And maybe another question regarding the device design. I noticed that you did an aortogram and a balloon inflation and also an injection at the same time. Many of us are used to sizing Evolut and not worrying about the coronaries because of the way the valve is designed. This is a straighter design, right? So having a bit of space around the side, having good sinuses, coronary heights, that's important with this device, right?
Yeah, yeah. Because, as you say, the design is strange. You don't have enough space. If you have to put an eye and be very careful when you measure the aortic sinus. The sinus should be room enough to have the leaflets on site, because there are some cases of coronary occlusion, but in my opinion, it's because there are not room enough. But the design is strange, so. Okay. You have to be careful.
You mentioned that you did a certain number of those cases with the classic VitaFlow and then some with VitaFlow Liberté. What are the difference in these two designs? The valve is the same, right?
The valve is the same. The difference is the delivery system. The delivery system is like the old classic core valve. You cannot retrieve. You have one shot, but even is a classic one, and even is not, you don't have the possibility to retrieve or to recapture the valve. The motorized system is very stable. We have not in 28 patients embolizations. We have not to put a second valve, even using the first generation.
But the new Liberté system, completely recapturable, the same as Medtronic to 75% and so forth. Okay. Elizabeth, you had a couple of questions for our panel and from the audience.
Yeah, do you think it could evolve to a single operator procedure because you only have the button to press as a second operator?
No. I don't think it's a single operator valve, because the second operator should press the button and the first operator should make minimum adjustments to be perfect. No, if you want to perfect implantation, you need two operators.
It is an interesting concept, though, because again, if you think about complete control in one person's hand, maybe it takes away a little bit that if there are two people involved in deploying the valve, maybe you lose a little bit of sensation between the two. But with this system, the button for deployment is actually at the top of the battery pack, and so if you've got one hand on the tip of the delivery system, one hand on the deployment button, you don't have the wire. So you got to make a choice: wire and tip of the delivery system, or not. So you need a third set of hands or a second set of hands for sure. Although maybe in the future it might be something that we look at. Thomas, would that appeal to you? Of course, I'm not talking about a single person doing a TAVI from A to Z, but a single person deployment.
Yeah, I mean, this may make the second operator less demanding in terms of experience, for example. Yeah, this is a procedure for which you may do it with
maybe some benefits.
Fellow or less experienced people. Yeah.
So Matthias, maybe I can ask you, because since I used it before COVID-19, so it's 3 years ago, there has happened a lot within TAVI in general. We have tried to optimize the way we implant this valve. You discussed the Cospo lab technique, which clearly have brought the pacemaker rate down, not only for this device, but for almost every devices. Another thing we are discussing is about commissural alignment to achieve easy access to the coronary arteries. Is this something which is possible with the current generation VitaFlow?
Yeah, it's a good question. Currently, we don't have any technique to make inside the body, commissural alignment. The engineers are working on the way that they load the valve after the case. So they load downside, and loading the valve as it, you can achieve 65 or 7% of commissural alignment, but it's not patient to patient dedicated.
But it might be in the future, right? Because you can see the 3 commissural posts very clearly in the same way as you can with Accurate. It's just that you have to deploy a certain amount before they come out, and manipulating at that point in the procedure, it's too late, right?
But I think this is one of the features they are working on, just to make it, to turn the valve in order to...
Yeah, it's still, like Medtronic, it's still a 2-spine device, so if you turn it a little bit, it flips back, so you need to turn it 90 degrees, but again, we'll see how it emerges.
Even though we usually do a coronarography after the TAVI, and we have not problem to engage coronaries with VitaFlow.
Okay. Yeah, again, those cells are big, right?
Yeah.
So it's good. Question from the audience, Lizzie. There's an interesting one there.
You mean this one? Huh? Is there any issue with disposing of the device within your center?
With the?
Within your center, if there is any,
I think it's about the battery pack, right? What do you just throw it in the bin, or can you recycle the batteries? You know, global warming and.
Is it eco-friendly?
It's not eco-friendly.
What's the footprint?
No, as far as I understand, that the battery pack is recyclable. You can take it out, you can keep it in your own center, and you can send it to sterilization, or I'm sure the company will take it back. But the battery pack, you can actually take out of the back of the handle, so I don't think you just throw it in the bin.
Yep.
But I don't know.
Okay.
Okay. So moving on to maybe another application for this device, an area that really with commercially available devices in Europe, we have had suboptimal results, to say the least, is that of aortic incompetence, and there are many reasons, of course, that aortic incompetence is different to AS, not least the ability to anchor a device within the aortic root. And we're very happy to have Professor Song from Anjin Hospital in Beijing with us, and he's going to talk to us about the Aurora study. Professor Song, we see you and look forward to your presentation.
For having me here, and it's been my honor, to report the Aurora study in China. I'm so glad, we have many friends here. We have Thomas, Lars, and Matthias, etc. Okay. So in China, actually, from Professor Wu's study, China DVD study, we have more aortic regurgitation. It's different, from the Euro Heart Survey, 2003. We almost have 16%, in hospital patients. However, we don't have the guidelines, recommendation for TAVI, for the patient with AR, especially if the patient is suitable for surgery. Not only from ACC or from ESC or China pathway of TAVI. We only recommend, transfemoral TAVI in experienced centers, and we need to screen for suitable patients. So what is suitable patients? So that's the reason why we measure the annulus level from the annulus, and we go every 2 millimeters above the annulus, so we can see if the leaflets can help anchoring the valve. And also we measure ascending aorta, so and also the LVOT level. And these two levels is not the main anchoring area, but they can help to stabilize the valve when you release. So we developed the new classification. We have 4 types. For the type 1, we have annulus level, and also we have 2 axillary assistant level. Sorry. We have the LVOT level and the ascending aorta level, to help anchoring the valve. And for type 2, and the main anchoring is also the annulus and the leaflets. And also we have the ascending aorta. For type 3, we have annulus and LVOT. But for type 4, we don't have any anchoring area in the 3 levels, or we just have the annulus level, I think is not stable. So we did the FAME study in China in 2021. We screened for 81 cases in Fuai Hospital and in Anjian Hospital. So this study was performed by Professor Wu and me. And finally, we included 32 cases. And we have different types for type 1, type 2, and type 3, almost average. And from the FAME study, we can see the annulus diameter is main diameter is 27, and we have 25% of patients. They have annulus diameter is over 28 millimeters. So I think we have a big sinus and also the big annulus. It's very interesting, we used 2 kinds of self-expanding valves in the FAME study. But you can see we have a tapered shaped frame, and like VitaFlow, we have a tubular shaped frame. So we can see the device successful rate for both valves is different. For the tube-shaped frame, we have 100% device success. So all these valves are the first generation. It's not recapturable system. But unfortunately, we have high rates of pacemaker rates for the FAME study. I think that's because, we use the first generation of self-expanding valve. We don't want, the valve jump to the ascending aorta. So usually we put it a little bit deeper, than the second generation. So that's the reason why we have the depth is a little bit higher, than the nominal depth. For the VitaFlow is about 8 millimeters, and for the tapered shaped frame, we have even deeper implantation. So after the FAME study, we invited 14 centers in China, and Professor Wu is a general consultant, and we have Thomas, Nico, and Hassan to be the international consultants and to do the Aurora study. And until now, because of the bad situation of COVID in China, we only screened 44 patients and include 23 patients. And the main age is 76 years old, and the STS score is very high. And the main diameter of annulus in this study is 26, and we only include maybe 13% of patients is more than 28 millimeters of the annulus diameter. I think this is a typical case of the Aurora study. 74 years old male patients. You can see this is a typical anatomy of PUAR in China. So we have big annulus and there's no calcium in the valve. So from the annulus level, the main diameter of the annulus is 28.5, and the aerial OT level is more than 31 millimeters. But fortunately, we have the ascending aorta is only 34 millimeters. So absolutely, this is type 2 for the patients. And also, we can see we measured every 2 millimeters around the annulus, above the annulus, so we can have anchoring area from the leaflets. This is 2 millimeters above is 27.5 and 27.6 in 2 and 4 millimeter, and 6 millimeter is also around 28 millimeters. So we have good. We are confident, to include such a patient, to to the study. And we use a mic anesthesia, and this is same technique as Matthias. So it's all in one. We only use one artery access during the procedure. This is you can see the picture. We can go through from the same sheath. This is a procedure. So you can see there's no calcium, and it's a big sinus. And usually we pace for 180, to help stably release the valve. And when we release 2/3 of the valve, so we can check the position to make sure, we have a good position. And usually we will put it, a very high position to avoid the pacemaker use after the procedure. So when we check the position is good, then we slowly release the valve, and be careful with the tape. This is the final result. So you can see it's a very high position, and there's no regurgitation after the procedure. Okay, I think transfemoral TAVI for AR is challenging and associated with unpredictable outcomes right now, because we don't have special devices for AR. The new TAVI-directed AR morphology classification was developed, to screen suitable AR patients in our study. And this ongoing study, I think, demonstrated is excellent clinical outcomes in suitable AR patients. However, I think the next generation of TAVI system for PAR are expected. Thank you.
Thank you, Guanyan, for that fantastic presentation. And I've no doubt there are lots of questions, indeed, from our panel. Can I start and ask you, when we've used other devices in Europe, we've seen that oversizing was one of the most important elements that predicted success, and we were always looking for 20 or 30% oversizing. What is the minimal amount of oversizing, be it in the LVOT or the annulus, that you would accept to take a patient on?
Yeah, I can show you in this slides here. You can see in the Aurora study, for the annulus level and the VOT level and the ascending aorta level is, I think we include is 10% oversize is good.
Wow, that's impressive. Lars, you guys did some work on this before with Fadi.
Yeah, and I think oversizing can be good and can also be bad, depending on the design of the stent frame. If you, like this one, have a cylindric stent frame, I think it can be an advantage to oversize to have a better anchoring in these non-calcified aortic annulus. But if you have a tapered stent frame configuration, it may actually pull the valve towards the LV. So I don't think for all valves it can be recommended to do aggressive oversizing, but I think if you have a cylindric stent frame like this, it may be useful.
Thomas,
this is important here because there was a matching between this new classification and the device oversizing. Yeah. So they were not using the oversizing for all comers, I would say.
Yeah. Thomas, Guanyan showed us Professor Wu's data from before, suggesting that maybe the prevalence of aortic incompetence in Europe and Asia, and particularly in China, may be different. We just don't see very much AR in Ireland. Do you see much of it, particularly amongst elderly patients that aren't good surgical candidates?
I mean, there are few patients that are referred for surgery for a pure aortic regurgitation in the elderly population. And those who have aortic regurg, they have also other disease like aortopathy, which needs ascending aorta surgery. That absolutely, we don't see them much.
So I would just say one thing here, Darren. First of all, if you don't offer the therapy, patient won't come forward.
Yeah.
So that was the same we saw before TAVI. Patient with aortic stenosis didn't come forward because there was nothing. And we all know we're quite reluctant to take this patient on board for TAVI.
Yeah. Matthias, your experience in Argentina, are you treating any aortic incompetence with this device?
Not yet. Not yet. I had 2 cases, but I decided to go for another device.
Okay.
Because the the aorta was big, so angulation, not yet.
Okay.
Darren, one final word. So this study, I mean, the preliminary data that Song have shown, are based on this new classification, which I think we need to validate a bit more, but it's very interesting. And the other thing is they validated that the outcomes, they compared VitaFlow versus the venous valve, and the outcomes were better.
Yeah.
And now they are using VitaFlow only on a prospective study.
Yep.
Enrolling in a large number of centers in China,
Yep.
which has been declared in clinical groups. So probably next year we have better data.
I mean, certainly very interesting. Again, it was a small sample size in that initial study, and the devices weren't recapturable. So with that, it is challenging to make strong conclusions. So with that, Guanyang, Professor Su, thank you for joining us, and obviously Professor Jimbo-Go, who joined us earlier. I'd like to thank MicroPort for sponsoring this session. Angela, Matthias, Lizzie, Lars, and Thomas, thanks for joining me here, and thank all of you for spending the time with us, and wish you an enjoyable rest of your day. Thanks, everybody.
Thank you, Darren.